I want to introduce Dr. Ramachandran again. She was with us last night, and at the risk of being repetitive, there are some people that just joined us today, but I'm going to give you her vita. She has her AUD from Wayne State University. She has her PhD from Wayne State University. She's the head of audiology at Oticon, and she's past president and board of directors of the American Academy of Audiology. So please welcome Dr. Ramachandran again.
All right, thank you very much. I know we're getting on in the day here, so appreciate your time and attention here. I'm going to hopefully get our slides up. So I'm going to be talking about a brain hearing approach to patient outcomes. So yesterday we were, and so I apologize, I do know that there's some people on who weren't on last night, but we were talking about patient outcomes and how to set people up for having good outcomes. And one of the things that we talked about a little bit was just sort of how to measure that, right? Like what's the metric that we're using to really understand, and we can use qualitative metrics and so on, but I'm going to be specifically talking about sort of the brain and okay, great, and how we can go about understanding what's happening in the brain in order to evaluate our fitting outcomes and so on. So you guys have heard my disclaimers already. I do work for Oticon, receive a salary. All right, so I'm going to be talking about a few different things here. Our brain hearing philosophy from Oticon, and then many of the ways that we go about measuring that. And then lastly, what's the application for clinical decision making? I will kind of stop for a minute in between these sections here, hopefully if I remember to, just to make sure, if we have questions or comments, that we can go ahead and do that, because there's a lot all at once to remember otherwise. And then, of course, if we do that, we'll just want to make sure that we use a microphone so people online and in the room can hear each other. So as head of audiology at Oticon, I am really fortunate that I get to serve on the management board of what's called Eriksholm Research Center. Has anybody heard of Eriksholm at all? Okay, a few people. So Eriksholm is our cognitive hearing science research center. So this is not the place where we do research and development for products in any way. This is all about cognitive hearing science, and then we can use the insights from this research center in order to really not understand what we can do with hearing aids, but rather what we should be doing with hearing aids. Because we've really gotten to that place now where there are many different directions that we can go with our technologies, and it really gets to be like, what's the thing that's going to move the needle for somebody in terms of good outcomes? So Eriksholm is mostly funded by the William DeMott Foundation. It's intentionally separate from our corporate facilities. It's about an hour and a half outside of Copenhagen, which is a long way if you're in Denmark, not so much in the US maybe, but it's intentionally set apart so that they're sort of not polluted by the commercial needs of the organization, that they really are a very academic group of people, and they're collaborating with academic institutions all over the world. The research is all online, so if you go to eriksholmresearch.com or just Google it, you can kind of see like where hearing aids going, where is our imagination taking us in terms of, what are we thinking about in terms for amplification and so on. And they would love it if you checked out their website or, follow them on LinkedIn. When they see new things, they go ahead and post those as well when new research comes out. So with Eriksholm Research Center, they have 4 areas of focus, but the primary being cognitive hearing science. And Oticon has been using the term brain hearing sort of as a trademarked comment for many, many years. there's a reason for that. And everybody's talking about the brain, right? Like you hear with your brain, not with your ears. We know that. We all know that really well. Patients actually don't really think about that very much. A lot of them are surprised when they hear that, and I'm sure you've experienced that. But we do think about the brain. We've been thinking about that for a long time and really had a separate dedicated research facility to that. And so one of the things that I want to emphasize is, from a manufacturer perspective, putting that hat on, we're kind of really trying every single time we launch products to let you understand what we're doing with that. So it's not just a question of, okay, you hear with your brain, and then you were focusing only on technical measurements or speech and noise perception. We really want to understand what's happening with the brain in order to facilitate this. And then we can use some of what we've learned here for the purpose of making claims and things like that. And so the research that I have was sort of predicated on that, but they're good examples of how we're applying this research. So there's this whole underlying body of research that we're approaching, really trying to develop technologies to understand what is happening in the brain when it comes to hearing and hearing devices. And then we'll occasionally use some of that in order to support our hearing aid research for you in order to make good decisions about what we can do for our patients. So we do hear with our brain, and when we come in, we talked about this yesterday, why are people coming in? They're not coming in because they have trouble hearing. They're coming in because they have some relationship problem in most cases, and it's usually caused by communication disorder. And so that's really what we need to be trying to treat from a purely hearing perspective is not, so we've got their emotional components that we talked about last night, and the hearing aids can't fix that. But what they can do is amplify sound in a very good way in order to support what the brain is doing, at least from a hearing point of view, to support effective communication, and then we can work on those emotional components. So there are some steps here in terms of turning what you hear into effective communication. And what you're seeing here is a very theoretical model, right? We have to work on theoretical models when it comes to the brain, because effectively, your brain basically is just meat with electricity in it, right? It's not sorted out neatly into these compartments. But at the same time, it kind of is a little bit. There are specialized areas of the brain for understanding speech and motor control for speech, for example. And so you do have specific areas of the brain that are specialized for certain functions, but they don't exist kind of in this nice pristine model. And we really need to do a lot of work to try to understand where it's happening, how it works, so that we can then understand what the impact of the technologies are on those outcomes. So I'm going to talk about outcome measures and why this is important. And this is just going to be a little bit of a review from last night. So if you are already with us, were with us last night, some of it will be a review. But I would just want to point out, what are the limitations of our current outcome measures? Like, why is that not good enough? And so again, why are people coming in? All sorts of issues related to life, right? They have challenges with life because of their hearing disorder. And we end up using really, specific metrics to try to understand whether the technology is beneficial. So you can do a whole bunch of different things. You could do, and they're all valid and they all have their place, but they all have benefits and limitations as well. So you can look at the technical performance of devices. You can put a hearing aid in a test box. You can do real ear. You can do all sorts of things like that to just really understand what the hearing aid is doing. You can use subjective and objective data, so you can have somebody telling you how they feel, or you can actually measure something that's going on. And then you have different things like benefit, satisfaction, and usage. Those three things are related, but they are not the same thing. And you guys all know this, right? Because you can, in fact, hit certain targets with gain, and the person might be getting a lot of benefit, not so much of the satisfaction. And if they're not satisfied, they're not going to use the devices, and then you don't get the benefit, right? So they are related in that way, but they're not necessarily measuring the same thing. And when you look at your outcome measures, you need to understand what it is that you're measuring. Is it benefit? Is it satisfaction? Is it usage? And then how are those three things related because they're not always as overlapping as we would like them to be. So you remember this from last night if you were here. I showed this study, so I want to kind of talk about it again. So this was the study about looking at the methods of fitting patients, whether they were fit themselves or whether they were fit by the audiologist using the exact same technologies. And what you'll remember is that we went through and we had a bunch of different outcome measures, and I put the wrong slide in here, I apologize, but there were a whole bunch of outcome measures, things like the profile of hearing aid benefit and the HHIE and the connected speech test, and there were no differences on the outcomes. You guys remember this? Okay. Why is that the case, then, that you could have these two groups have such different outcomes in terms of whether they were going to keep their devices? And the answer is that these are missing something. These other measures were missing something fundamental that the patient was experiencing. They weren't tapping into it. And so it's a sensitivity issue with the metric. Is it really going to give us what we need to know? Sensitivity of metrics is also an issue of, is it asking the right questions? But then there's also the case of, has it kept up with technology? So some of these should look familiar. These are, the types of metrics you're going to see in hearing aid research. Look at the publication dates of these. Okay, right? Like, there are a couple that were done in this century. 20 years ago, right? These are the metrics, and everybody will go, oh, but the research says this, using that metric. So let's pick my favorite-ish. I say that sarcastically. It's virtually impossible to get something published unless you have, like, the AFAB in there when it comes to hearing aid research, okay? And look at this. So anybody fit this hearing aid before, by the way? Yeah, okay. So the AFAB was published in 1995. First digital hearing aid came out in 1996. Okay? And if this is published then, that took like a year to get it published. So then they were collecting data for the 2 years before that. And so they're using pretty old technology. And so this was the multi-focus that was being sold back in 1995. And then so they did this study and they validated it, and they did validate it at the time. 90 men, 38 women. All subjects wore conventional analog hearing aids. 58% monaural fittings, because you guys remember back then, right? Yes. They didn't, yeah, no. In fact, it was considered unethical sometimes that people were told, oh, you don't need two hearing aids. You don't need to fit somebody with two hearing aids, right? And so, this was a while ago. And so you got to be thinking about, okay, well, what levels of difference was this type of metric able to show at that time? And actually, I've been going back and finding some things. The AFAB, in a lot of cases, couldn't show the difference between digital and analog technologies. It couldn't show the difference between 1 ear and 2 ears being fit. Things that we kind of take it for granted now. And so, the question is it the right metric for us to use? So this is my little dog, Ginny. Thank you. She's a cutie, yes. When you got a little Yorkie, this one's not mine, but when you got a little Yorkie like this, and they're a little puppy, and they're 2 pounds, they have to go in the little dog scale, the little baby scale. Because if you put them on the big dog scale, you can be kind of off, because it is not made for that, right? So this big dog scale is made for big dogs, and it's not as sensitive to the weight of what that Yorkie is. And of course, if you're too big of a dog on that little scale, it's not gonna work either, right? And you don't wanna be off with that little tiny dog. Because if you're off by a pound, which you could easily be, or even half a pound, right? Half a pound for that big dog, that's not a problem. Half a pound for a 2-pound Yorkie, if they're gonna have to have some sort of procedure, right? Medical procedure, and you're giving them anesthetic, you need to be right? So that's why we need to be thinking about, is the metric that we're using appropriate for the question, right? And so I want you to think about this for a minute. with the AFAB, okay? But let's set up a scenario, right? So we've got a kid who, again, I think I gave my theoretical kid last night. Got a kid, grows up, goes off to school, comes back, I'm having trouble in this one situation, okay? So we say, okay, you're having trouble with this professor in this lecture room, so remote mic, we're gonna do an EduMic or something and see how it goes, okay? And then he comes back and he's like, yep, that was great. So we administer the AFAB to understand whether we have succeeded in our treatment. And so we administer questions like this. And I would like you to think about how you would answer these questions. I can follow the words of a sermon when listening to a religious service. Did this change for this child or young adult at all? Maybe if he used it, if he thought to use it, but that wasn't the problem that he had, and he might not even go to religious services, right? When I'm in a small office interviewing or answering questions, I have difficulty following the conversation. I'm not entirely sure how I would answer that right now. I don't usually have that experience. When I'm talking with someone across a large empty room, I understand the words. We're in a crowded room, but if I talk to you, how often is somebody doing that to you, right? That you're talking across a large empty room. Do you know the answer to this question? Here's an oldie but goodie. When I'm listening to the news on the car radio and family members are talking, I have trouble hearing the news. Who would do that? Why are you listening to the news while your family members are talking, even if you were? And then we say, okay, I miss a lot of information when I'm listening to a lecture, right? So we have this one metric where we had this excellent experience for this young adult because we absolutely 100% fixed the problem that they came in with. And when you do the AFAB, it will show that there was no difference and that your treatment was not effective, okay? And we're using these metrics regularly to evaluate outcomes. This was one of the metrics that was used to evaluate OTC hearing aid versus audiologist fit hearing aid. And are we then able to get to the answers that we need? From a political perspective, this really bothers me because the National Academies of Sciences, Engineering, and Medicine, who brought you OTC hearing aids, is now looking into meaningful outcome measures in adult hearing healthcare. And it makes me nervous because they're sort of trying to come up with a uniformity to outcome measures, determine a core set of existing standard outcome measures that define the core outcome domains. And this makes me nervous because this was a group that looked at evidence from last century, and said this is good enough, and so, and they're really focused on current outcome measures. But this group, has potential to make recommendations that can then say, okay, well, if you work for the government, if you work for the VA, you need to include these outcome measures. If you're going to have research published by or funded by NIDCD, you need to use these outcome measures. And so I think there's a real potential to impede progress from a scientific point of view, and then from a funding point of view as well, right? Because if we're using measures that are showing no differences, and the government sort of told us to use those measures, that could result in some problems. But at any rate, all of that aside, this is why it matters to us what the brain is doing and being able to develop appropriate outcome measures to understand that. And that's not an easy task. That's why we are using really old outcome measures, is because it is hard to come up with those new and better outcome measures. But it is something we spend a lot of time and resources on as a company. So, you probably have all seen a picture like this, right? And as clinicians, we spend a lot of time down there by the cochlea, lots of time, and we know a lot about it, outer hair cells and inner hair cells and, traveling wave and all of that. And then we know some things about the eighth nerve, right? Because we want to make sure there's no tumors growing there and so on. If we're doing reflexes, we kind of know some stuff about the midbrain. And then magic happens up there in the cortex. And you see how little is reflected on the screen here. In fact, it becomes infinitely more complex up there, but we haven't had a lot of focus on that from a professional point of view. And there's a reason for that, and it's because really nobody knows. There's not a lot out there to know. And so this really still is a developing area. And frankly, the cochlea is too. I mean, we don't know everything about that either. I mean, some people were already practicing when they just were like, oh, outer hair cells do something, right? And so there's more to learn all the time. And being focused up there at that cortical area is something that is still very much in progress, okay? Now, how would you go about measuring, and mapping out how the brain does make sense of sound? There are different ways that you can do that. Techniques like MEG, electrodes, EEG, and different researchers will use different strategies depending on what questions they're trying to answer. And so some of these are very non-invasive, some could be pretty invasive. And so I'm going to kind of walk through particularly how we use EEG, but I'll show you some other independent studies that informed our choices for that. So I'm going to take a breather here for a second and pause and see, does anybody have any questions so far, comments, anything like that? Nothing online? No. Okay, perfect. All right, forging ahead. So one of the things I'm going to talk about is how we measure attention via EEG and selective attention. But I'll take a little detour before I get there, but this is sort of what this section is about. You can, in fact, see the brain tracking a speech signal. And this is a technique that was developed not all that long ago and was very early adopted at Ericsholm. And it's kind of all the rage now in the past few years when I go to some of the scientific meetings. But basically what you are looking at is the envelope of the ongoing speech signal. And if you use a good strategy to extract the signal from the brain, you can actually follow that response, that envelope in the brain. It requires machine learning in order to develop a machine that can do that. So AI is used across all areas of this from a professional point of view. So it's not just in the hearing aids themselves, but sometimes we need to use AI just to develop methodologies and research methodologies to understand some of this. But with machine learning, you can extract the ongoing speech signal from a cortical response. And not only can you do that, you can actually take multiple independent speakers, you can take background noise, and then you can actually see all of those in the cortical responses in the brain. And so it gives us a really nice opportunity to understand some of these aspects because, where is that response happening? And then when we adjust parameters of devices and the signal we're giving to the brain, can we affect changes there? So this is the detour here. This was not a study that we did. This was a study that was done in New York. But our researchers pay attention to all these types of things. We've got a lot of neuroscientists on staff. And this was a study that had only 8 adults, but this is because it was a highly invasive study where these adults had seizure disorders. And so they were undergoing surgery, brain surgery for their seizure disorder, and that's an awake surgery. They have to be awake and they have to be alerted during that time. So this is a lot of the types of work that some of the speech language pathologists would do, right? That they go in and they're wanting to understand what's happening in the brain, mapping in the brain for where the speech centers are so that the surgeon doesn't accidentally cut the wrong thing and cause all sorts of problems for the patient, right? So in the process of this alerting task, they actually said, well, while we're in there, would it be okay for us, because we want to understand a little bit more what's happening in the brain during a task like that. And so these 8 people allowed them to put needle electrodes right on areas of their brain during this surgery so that they could understand what was happening. And so they did, I want to see here, can you guys see on the screen my highlighter? Okay. Can they see it online? Cool. Okay, awesome. So they went into this area called Brodmann's area 41 and 42, which is up in here. And I wanted to show you the cross section because I wanted you to see like how far in they had to get in order to place these electrodes. So this is not a surgery you're going to do every day, and it's really far down in there. But there are localized areas of function within the brain. That's why they were named that way to begin with. Brodmann went in and kind of mapped out some of these areas. So we know that in the Heschel's gyrus, primary auditory cortex, that's deep down in here, and then you've got the superior temporal gyrus, or the non-primary, kind of out here in this area. Okay, so they took these electrodes and they placed them in that area of the brain. Okay, and so you can see what that looked like. So they put a whole bunch of little electrodes, like needle electrodes, so they would be kind of just dispersed over the surface of the cortex there. And then what they did was they had them listen to speech. And they said, okay, you're going to listen to one speaker by themselves, and then you're going to listen to another speaker by themselves. And what you see here is just an example of the recording from a single electrode in the brain, okay? And so you have one electrode in Heschel's gyrus here, and one in the superior temporal gyrus. So they pulled these out just as examples so that you can see what the ongoing signal would look like, but basically then this all just becomes math, and they're figuring it out from the ongoing signal. But they wanted to pull this out just to show you, okay? So you've got speaker one, and that's what the spectrogram looks like. You've got when they were listening alone to that speaker, the lighter blue here is the response that was recorded. And it followed the envelope of the signal that the speaker was, that single speaker had. And then they did speaker two alone, and that's the lighter red here, okay? And that followed that envelope of speaker two. And so they knew what that looked like, and then they went and put the two of them together, okay? So they had two speakers happening at the same time, and they recorded the response. So in Heschel's gyrus, what happened here for this person was when they heard the two overlapping speakers, their brain, that area of the brain, that neuron that was being tested, was following one of the two speakers, this one, right? You can see how that matches up there. It was not following speaker two. And they think that this is related to a little bit to the tonotopicity that is still present up in the primary auditory cortex, that you have specific areas that are focused on specific, sort of like a register of speech, and then another area might be focused on this second speaker, okay? But the point is, what we're seeing here is that this one electrode or one area of the brain is following an individual speaker. And you can actually see that happening. Then, when you look at some of the other electrodes that were in the superior temporal gyrus, you actually see two things. Well, so the first one, they actually said, okay, let me go back here. They said, listen to speaker one, and they recorded the response. And they said, listen to speaker two, and they recorded the response. What you see here is the blue and the red, which look pretty much the same. When they told them to listen to speaker one, it followed speaker one. When they told them to listen to speaker two, it followed speaker one, okay, when the two of them were happening together. When you look at the superior temporal gyrus, they said follow speaker one, and that part of the brain at the same time followed speaker one. Then they said, okay, we want you to listen to speaker two. And then that same electrode, that same neuron was following speaker two. Okay, so what we're seeing is evidence that there are, in fact, independent areas of the brain for things like orienting and focusing. And you have to do that. You have to be able to orient to your sound environment. You're getting this cacophony of sounds, and at some point your brain has to go, oh, that's that thing, and that's you, and that's a car. Like you have to separate things into individual auditory objects in your brain. Okay, and that has to happen somewhere, and it looks like that's probably happening in that primary auditory cortex area. But then at the same time, you don't need to attend to everything. And in fact, that would be pretty much impossible for us as humans to be attending to everything all the time. So it's there, it's being represented in the brain, but then being able to purposefully attend to a particular speaker is something that actually happens in another part of the brain, okay? So that's the focus area, which appears to be around about the superior temporal gyrus. And so knowing that information gives us an opportunity then to use metrics where we can use timing differences and looking at specific areas in the brain to understand what's happening. Is this actually orienting a response? Is this a focusing response? And then understanding how different parameters of hearing aids, how different parameters of hearing impact that situation, okay? So that's what we're talking about when we talk about brain hearing. The studies that I'm going to show you, again, are from our work at Otakon with the technologies. So there's a whole other body of literature out there. Again, if you want to go to Eric's Holmes' website, you can kind of look at some of the underlying early literature on this and the techniques that have been developed over time. But when you look at the technologies themselves, I just want to make sure that you're oriented to this in case you're not an Otakon expert. Since 2016, we came up with Open, and then OpenS, and then Otakon More. Real and Intent was our latest launch, okay? And each of these were big jumps in signal processing for cleaning up the sound signal. Okay, getting rid of noise, ensuring audibility, and so on. And what you see at the top is the terminology that we use to describe our noise reduction systems. And I wanted you to see what that looks like over time, because basically I'm going to be kind of jumping around with the technologies, and I want you to see, I'm going to be talking about kind of all of these, and they use the marketing names for those, but there were 4 different iterations of this cleaning up the sound signal platform, okay? Now, Open Sound Navigator was what we used in Open and OpenS, and this was a rule-based strategy for improving the signal-to-noise ratio. And then with Otakon More, we introduced a deep neural network addition to improving the signal-to-noise ratio. So I know we just heard kind of some things about directionality and noise reduction, and I just want to clarify what we're trying to do here, because it's going to be pertinent to why are we setting up our research studies the way that we do, and what are we investigating. So the concept of brain hearing, the idea that your brain really just does need a really good signal to orient to what's happening around them, around the person, is sort of a core belief that we have informed by the research on how the brain works. So with Open, the idea was you want to leave the sound scene open. Directionality, as you heard a little bit ago, is an amazing way to improve the signal-to-noise ratio. The caveat, it is an amazing way to improve the signal-to-noise ratio if and only if the speech and the noise are spatially separated. When the signal of interest is coming from the front and the noise is coming from the front, and it doesn't matter where, if it's the front or wherever, when they are coming from the same location, directionality does not allow you to pull out the speech from that noise, because it's actually just trying to cut out noise elsewhere, but it doesn't work then. And that means when you're in a reverberant environment and sound is bouncing all over the place, you're necessarily going to end up with sound in the front field. Or if you're just in a typical type of scenario where people are getting food and we're having dinner or something like this in a restaurant, you're going to have noise all over the place. So that is referred to as diffuse noise. And historically, we hadn't had a good way to handle diffuse noise in hearing aids. We just had directionality since the 70s. And again, that works really well when the speech and noise are separated. We don't want to throw out the baby with the bathwater, but you don't want to overuse it in situations where it's not beneficial. And so with Open, we came up with a way to make a rule-based decision to do extremely rapid gain reductions so that you can basically just amplify the speech more than the noise. And if you do it fast enough, then you can improve the signal-to-noise ratio. Traditional noise reduction has been based on modulation analysis, meaning that you look at a signal over time, and over time, if it's speech, you want to preserve it, and over time, if it's noise, you want to get rid of it. And so the idea that noise reduction didn't improve signal-to-noise ratio, that's where that came from, because traditional noise reduction didn't. Back in 2016, when we came out with open, we had a faster way to make this decision. It was rule-based, but we could make it. And so when we could make that decision, you could then improve the signal-to-noise ratio using noise reduction as a strategy, and you don't have to use directionality to do that. That said, should you continue to use directionality under the appropriate circumstances? Yeah. So we combine those two in Open Sound Navigator. We have a way to handle diffuse noise sources using the noise reduction strategy, and we had a way to handle directional types of noise sources using directionality. And so you use the appropriate tool for the correct situation. So then you're not over-relying on directionality, you're not unnecessarily shutting down the environment, because then you have access to your brain, to those sounds around you. It can do its job of orienting to the sound scene, and then it can focus the way that it's supposed to. When Moore came out, we changed that rule-based noise reduction strategy to a DNN-based strategy, a deep neural network. So this is using AI and training AI to say, okay, here's a system here we've got that we're going to train. We give it a clean speech signal. We give it the same speech signal in noise, and we give that speech signal in noise, and we say, clean it up. And the system randomly does things, and then you show it the clean speech signal, and it's like, oh, it mathematically does all this, but it says, okay, this is where I was supposed to be, and I'm not there. You adjust the parameters, and then it learns, okay, this is what I need to do. And it does that over and over again until it learns patterns of this is how I identify speech, this is how I identify noise, this is how I get rid of what is actually the noise, okay? So we train it using a supervised training strategy or supervised learning strategy, and then it doesn't learn anymore. We put it in the hearing aid, and then it uses what it's learned. So we've been using that since Moore. With Real, we added in some noise reduction strategies for wind and handling noise and for sudden sound. So this was a super fast transient noise reduction strategy. And so what you're going to see is how does that impact the brain? So that was added into the noise reduction strategy. And then with Oticon Intent, we've added in some intent-based sensors so that when people are moving, and head movements and body movements, it can help to inform the hearing aid how much of that noise reduction and directionality to apply. So it's kind of the traffic cop there. And so that's the evolution of these strategies, and I just wanted you to understand that because it's going to be pertinent to what I'm talking about in terms of what the evidence is showing and why we set it up this way. So EEG is a methodology where you put electrodes on the brain and it's picking up the electrical activity at the surface. And so you use 64 channels in typical situations. And what we did was to look at trying to understand the orient and focus subsystems using EEG. So those areas I mentioned earlier. The test setup looks like this. Somebody's got these electrodes on, and I'm going to kind of go through it again, but what you see is there are 4 noise sources behind this person. 1, 2, 3, 4. And then you have 2 speakers in front off to the sides that this person was listening to. And when I say 2 people, these are speakers that are projecting the voice of 2 different speakers. Then you collect the data, you average it, you get rid of the artifacts and so on, and then what you're looking to do is to extract that frequency following response of the envelope of the signals and separate that out, and you can then see how salient that signal was to the brain. How well was the brain picking up any of these particular signals, okay? So you could do this back in the old way of like repeat the words back, but that only gets us so far. We want to understand some of the nuance to this. Where is it happening in the brain? And are there things that we could pick up that are more sensitive? So this is kind of what that looks like in the lab. Somebody's sitting in front of the computer. They're hearing the speech coming from those 2 in the front and then the noise coming from behind. speaker in focus, and a secondary speaker. So this was some of our earliest work, and they were told to listen to one speaker and ignore the other, and that there's always going to be noise in the background. They listened to speech babble for a little bit, and then this 30-second news clip would come on, and at the end they had to answer a question. So this was just to make sure that they were paying attention and engaged in the task. So what you have here is the results of the situation that they were listening with the hearing aids. So these are people with hearing loss. They're listening with hearing aids with Open Sound Navigator turned off. So this is the noise reduction feature is turned off. So this is just like audibility-based fitting here, right? So we're not trying to clean up the sound signal too much there. And then what you see down here are three situations. There's the speaker in focus that they were listening to, there was the secondary speaker that they weren't listening to, and there was the background noise. And what you have here is the correlation of the EEG signal to the signal that they were listening to. So we want to understand that correlation, and the higher the correlation, the assumption there is that the brain was more readily able to attend to that signal. Okay, so the interpretation of it by the scientists was that this is consistent with a focused attention, because they were asked to focus, but you know it's really about the salience to the brain. Okay, so what you can see here is that that speaker in focus, even when you have the noise reduction technology turned off, was pretty good, and this attention to the other two sound sources was quite a bit lower, and that's good. That's what we want to see. But the question is, can we do better? And so what we did was turn on Open Sound Navigator. And what happened was that we had three things happen here. So our ability to attend to the background noise decreased significantly. Okay, so we're cleaning up the noise signal, and all of this noise that was happening behind the person really dropped in terms of the brain salience and picking up that sound signal. What was interesting, because we did manage to leave the sound scene more open rather than just closing things down with traditional directionality, we were going to, again, use both of these so we're not overusing directionality. So we're using the noise reduction as a primary strategy to improve the signal-to-noise ratio here. And so we wanted to see, can I understand this secondary speaker, even when I'm not paying attention to them? And yes, that was much easier to pull out. The brain was clearly paying attention to this other speaker. So then you're like, is that a good thing or a bad thing? Right? We worry that, you know, if we give more access to people in terms of sounds, is this going to be beneficial, right? But I can sit here and I can come up and we could have a conversation with Gary and Dave here, and it'll be like, hey, what's going on? And then Gary says something to me. Where is he?
What are you talking about?
He's over here. And I need to say, oh, wait, somebody over here is speaking, right? And I need to orient to what's happening around us. And so if you're in a conversation with more than one person at a time, sometimes they're not directly in front of you. And you do need access to the other people around you to follow a normal conversation. Because again, communication is the outcome that we're looking for here. We're not just talking about hearing. We're not talking about can you repeat words. We're talking can you have a good conversation with somebody and communicate effectively. And so if you're in a conversation with more than one person, a lot of times you are standing at a 45-degree angle. A lot of times you're in background noise, right? And so we want to make sure that you can attend to the other speakers as appropriate when you want, because you may need to switch attention occasionally. And so this is why I think we've got, I know Kathy's a pediatric audiologist, right? So, but you know, historically they've turned off noise reduction or directionality noise reduction for children for the reason that they need access to incidental learning and overhearing, right? And you know what, adults also benefit from context. Understanding what's happening and being able to follow a conversation actually really gives you a lot of top-down processing as well. So if we can give the brain a clear enough signal to allow the brain to pay attention to multiple speakers, it's our philosophy that we can and should do that. But this study gave us a lot more confidence in saying that, because while we can understand this speaker much better, we could also understand the speaker in focus better. So there was no detriment to having this other speaker accessed. In fact, it was improved for the speaker in focus. So that's telling us is we're giving this brain a better, clearer signal for multiple speakers, and that allows the brain to do its natural job, which was orient and focus, right? All right. So that was with Open Sound Navigator. So then we went with Oticon More and looked at this a little bit more deeply. And we actually used timing differences to understand this orient versus focus subsystem. So that orient system occurs earlier in time than the focus subsystem. Okay? And so we're able to actually look at the strength of the signal and that correlation between ongoing speech and what's happening in the brain, but to do it at different points in time. So it's not just a question of, is it following? It's when is it following, and what's the strength of the signal when it's following? Because when it's following determines where in the brain it's actually happening, because it's a hierarchical process. Just think of the ABR, right? 5 milliseconds is kind of where you're looking for that, wave 5, right? So you are, no, anyway, so you just, it's time locked, right? It's supposed to be there at a certain time, and if it's not there at that time, then something's wrong, right? Same idea here. We want to know where in time this is occurring, because then it can help us understand where in the brain it's happening. All right, so first off, we looked at more sound intelligence, again, the noise reduction system. We looked at it off versus on. And in this case, we were looking at the same setup. You can see there's 2 speakers coming from the front, 4 speakers in the back with background babble. They're supposed to listen to one and ignore the other speakers in the front. So more sound intelligence off, you have a certain amount of correlation to what's going on in the brain. And then when you turn more sound intelligence on, you have a higher representation. So there's a greater ability to understand those speakers. And you can see that that is different. And what you see here, is the full sound scene. So this is like representative of everything, and that's sort of that earlier level in the brain, that orient level. Then we ask them to focus in, and you can see that correlation then with the individual speakers goes higher, and that's what it looks like with more sound intelligence off. And then you turn it on, and you get a significant improvement in terms of that salience in the brain. So again, you're just giving a clearer signal to the brain, and so it's able then to do what it's supposed to do. It's able to orient better, which you see here, and then it's able to focus in better. And then we also, again, saw an improvement in the salience of the secondary speaker, the one that they weren't paying attention to, but it's not at the sacrifice of listening to the intended speaker. Both of those went up. Okay. So again, it kind of gives us a lot of comfort that we're moving in the right direction when it comes to that noise reduction strategy, that open and giving people access to more sound is in fact effective. All right, and then the latest one was with Oticon Intent. 30 experienced hearing aid users, mild to moderate hearing loss, and in this case, we actually had been using, because we had, with Oticon Real, we had our sudden sound stabilizer, which is our transient noise reduction system. So in this case, again, you have the 2 speakers coming from the front, and then there's a speaker coming from the front here, and then you had noise, and that noise was actually interspersed with sudden sounds. And what we know is that, in fact, when you have distracting sounds, it's more difficult to focus. And so we purposefully put those in there because we wanted to test that system. And again, could we see a difference in the brain from the transient noise reduction system? Could we improve focus despite the fact that these distractors are there? And what you want is to maintain the attention to the speech, but we wanted the attention to those background sounds to be decreased. Okay, so that's what we were looking for. And so what you're going to see here is the salience, that correlation of that brain response to the speaker for speech on the left side and then sounds in the environment on the right. And we did it with the more sound intelligence noise reduction feature on and with it off. And what you see on the left side is that these correlations were pretty nearly identical. And so we could see that you're getting access to speech no matter what, whether that was on or off. But then the sounds in the environment differed depending on whether that was on. And so when it was on, when that noise reduction strategy was on, we could see that there was less attention to the sounds around the person in terms of the just straight up noise compared to when it was off. So to summarize up this section here, you can use things like EEG, MEG, deep electrodes to understand what the brain is responding to. The data does suggest to us that there are orient and focus subsystems within the auditory cortex, and that you can measure these, and in doing so, you can actually be able to show differences in attention and being able to attend to speakers of interest, not speakers of interest, background noise, and that you can actually see differences in outcomes based on the parameters of the hearing aids. In people with hearing loss. And so this is something that I think is really, really important, because it's not just about, am I getting the words right? It's about what's going on up here. And we'll talk about a little bit more about why that matters so much in a bit. So I want to pause again. Questions, reflections, anything online? Yep. It'll be more fun if you ask questions. That's right. Okay, we'll keep going then. Wonderful. All right. So next up, in addition to attention, if you're attending to a signal, that takes effort to attend to a signal. And so the effort expended when listening is something we also want to pay attention to. So a few years back, Eric's Home will occasionally hold these big conferences to get consensus within the scientific community about topics in cognitive hearing science. And so listening effort was one of the areas that they focused on in 2016, and a definition was created within the scientific community that listening effort is a specific form of mental effort exerted when a task involves listening. And there's different ways that you can measure effort. You can ask somebody about how effortful something was, but we're looking for some more objective measures that we can also rely on. And so we want to use both of those. There's self-report is important, but then we can correlate self-report to objective metrics, and then in some cases it's easier using the objective metrics to get this information. One way to do that is to look at pupil dilation. So pupil dilation is an autonomic nervous system response. It's a reflex. It happens, and you can't control it. It happens in response to a lot of different things. So different lighting scenarios and excitement and effort and all sorts of things will cause your pupils to dilate. And so because effort is one of those things, and you can use this as a proxy for effort by measuring pupil dilation. This has been happening since the 1970s. This is not new. This has been used extensively in other fields. We've just been using it in our field more recently because the ability to actually do these types of measurements has increased dramatically over time. So this is kind of what that would look like. They would have, like, in the past, they had goggles on. Nowadays, you can actually just put a bar on, like, the computer that I have in front of me, and you can actually measure pupil dilation using something like that, which is really impressive. It's getting to where you can actually start to use ambient lighting in order to measure it. So we've got a ways to go before it's clinically applicable, but it's moving along. The technology is getting better to where we could actually potentially use it clinically. We're not there yet, so I'm going to show you what we've got in-house to be able to use. But basically, you can measure the pupil dilation. If you've done VNG testing, you can kind of imagine how easily you could do this, right? And there's different things that you can measure with pupil dilation. You can measure the peak, and you can measure it ongoing and so on. So when we started doing this, we looked at the peak pupil dilation. And again, from historical data from other professions and other areas of science, we knew that more effort is expended. The more effort that's being expended, the higher the pupil dilation, or the greater the pupil dilation. And so you can use this peak as a metric, as a proxy for some attention. And so the way this test is set up is you create a baseline scenario, and that's really important because, as I said, a lot of things can impact pupil dilation. So you need to get a good baseline and say, okay, this is where this person is at right now, and then you change one thing, and only one thing, because you don't want anything else impacting that pupil dilation. So, so basically you get this noise presentation, they're listening to that, you get that baseline pupil dilation, and then they listen to a sentence, okay? And you look for how much attention was paid to that sentence, and they were actually asked to repeat the word at the end of the sentence, just again to keep them engaged and for some other measures that they were doing at the same time. And you can see what that measurement kind of looks like on the screen there. So same task, you see this again, right? You've got the two speakers in the front, background babble, but this time, in addition to asking them to repeat words, they're measuring their pupil dilation at the same time. As I said, noise is presented, get the baseline, and then you get the peak pupil dilation. So I'm going to show you what that looked like relative to actual speech intelligibility outcomes. And I hope that this will highlight why these brain hearing types of metrics are important. So what you see here right now is speech intelligibility. So we're stepping back from pupil dilation here, and you can see the speech intelligibility percentage here on this right axis here. And so it can go anywhere from 0 up to 100%. And you can see the signal-to-noise ratio plotted down here. So a good plus 15 signal-to-noise ratio, nice and quiet, down to negative 10 dB SNR, okay, very noisy. And what we have here is performance in terms of speech intelligibility for Open Sound Navigator off and Open Sound Navigator on. So again, the noise reduction system, this was our rule-based noise reduction system. And so what you see is at a good signal-to-noise ratio, no matter whether that noise reduction feature is off or on, you're getting really good performance, right? Ceiling performance here, 100%. And then as the task becomes more difficult, because the signal-to-noise ratio is getting worse, your performance starts to drop off, okay, as it should. When you have Open Sound Navigator on and you're cleaning up the sound signal with the noise reduction, you can see that you don't have quite the same drop-off. You actually get some improvement in signal-to-noise ratio before you get that really bad situation where you also see that drop-off. And one of the common metrics that is used is this SNR 50, which is at what signal-to-noise ratio do you get 50% of the speech correct? Okay, and then you can use that to say, okay, how much signal-to-noise ratio improvement do I have with this feature being on or off? And in the case of this Open Sound Navigator, it was a 5 dB difference. So there was the SNR 50 decreased by 5 dB. So you could be in a more difficult situation and get the same outcome, okay, is the idea. So you see what the performance here is, but then let's look at what the effort was to achieve that performance at the same time. So now I'm going back to just Open Sound Navigator off, the noise reduction feature off. And so you can see the performance plotted here, but then on the left axis here, you see the pupil dilation. And so you can follow it in that really easy signal-to-noise ratio, 100% correct. You don't have quite as much effort. And then the task starts getting harder, and the performance is still hanging in there, and the effort is still pretty low. But then as the performance starts to decrease because you're getting even more difficult, then your effort starts to increase. It's harder to do the task, right? And then you start to drop off in terms of performance. Now we're working really hard. Performance drops off even further. We're still working really hard. And then effort drops off. Why does effort drop off? You give up, exactly. So there's actually a rollover point for effort where you're no longer invested in the task because it's not possible to accomplish it, okay? And so we can see that happening here. When you turn Open Sound Navigator on, again, you already saw this performance curve, so you're getting better performance overall for at least in a slightly poor situation there. But look at what happens with the pupil dilation. So this is really interesting. Even in the simplest environments where you're getting 100% correct, with that noise reduction feature on, you have less effort that's being expended. Okay, and that's why these things matter. It's not just about getting there, it's like, what did it take to get there? Because if you're having to expend a lot more efforts to do something, even if you're getting the same outcome, what is that? You're not left over with the same amount of energy to do other things with, right? And so that's why this matters, that you want to understand not just what the outcome is, but what did it take to get there. Okay. And then what you can see, of course, is same pattern, which is that as the task becomes more difficult, performance starts to drop off, effort increases. But what's really cool here is that we actually were able to shift out the point at which they gave up by about 5, in this case, I think we're going in 4 dB increments. Okay, so we could push it out into a more difficult situation before they actually gave up. And so when you think about your, well, let me go on to the next thing here. Okay, so you can see here that I've plotted performance, and that's on the bottom. Okay, so we've got performance down here, pupil dilation up here. They did this with people with hearing loss, but then they also did it with normal hearing peers. Okay, and I give the marketing people grief because they put all of these in blue. So if you look at this blue line and that blue line, so unfortunately, sorry about that. So our normal hearing folks have this sort of teal color, okay? Age-matched normal hearing peers. And you can see as the signal-to-noise ratio gets worse, performance starts to decrease, as it's supposed to. For people with hearing loss who did not have Open Sound Navigator on, their performance dropped off faster, okay? When you turn Open Sound Navigator on, it actually followed the exact same pattern as people with normal hearing. Does that mean they have normal hearing? No. But were they able to achieve the same performance for this task? Yes, okay? And so that was a really cool outcome. But what did it take to get there? And that's what you see up here. You've got Open Sound Navigator off and pupil dilation. So as the task becomes difficult, effort increases, and then eventually it becomes too difficult and it goes down. They've given up. This teal line is the people with normal hearing who also give up eventually, right? If the signal-to-noise ratio is poor enough, they can't hear either. You guys know this, right? But then look at with Open Sound Navigator on, which is this line. Their give-up point was pushed out to the same place as the people with normal hearing. And that's really cool, because a lot of times we have patients coming to us and they'll say something like, I couldn't hear at the bowling alley. And I might go, well, I would have trouble at the bowling alley too, right? And that's true. We need to follow up with the question, but could everybody else hear and participate? I bet everybody else was also having trouble, yes. But were they able to function? And were you able to function? Were you able to stay engaged? Were you able to participate or not? Because that's what we don't want happening. We don't want them to start withdrawing and not going to things and not doing things because they're being excluded under difficult circumstances. And so if everybody else is having a struggle and you're having a struggle, that's fine. But what we don't want is for you to be left out of the conversation, right? And so we can see with this from an effort point of view that we're actually able to keep them under these circumstances in the game, as it were. So those are the kinds of things where effort and understanding that become important. All right, now that task I showed you was about that sort of peak performance, right? So it was like, okay, at the most difficult, I've asked you to listen to a sentence and now we're gonna see how well you do. That's not super indicative of real life performance, right? Because we tend to engage in conversations and over the course of time. And so there's other ways that you can measure pupil dilation over time. It's a little bit harder because, again, you have to control for a lot of other variables at the same time. So we're not just looking for that peak. We have to maintain all of those variables consistently over a longer period of time. And so that's a little bit harder task. So we didn't start doing that until our More Sound Intelligence came out. But what you can see here is you have pupil dilation recorded over a period of time. And what happens when you do a task, I showed you, you get that peak of pupil dilation. When you start listening, you're gonna get that peak. And so what is happening here is we're showing relative to that peak, how does the effort change over time? Okay, so they start listening, oh, my attention has been drawn to you, I'm listening to you now, but as I'm listening to you, the attention starts to go down a little bit because now I'm engaged in the task, I'm not having to orient to it and so on. So you can actually see this change over the course of time. And that's what we wanted to really investigate is, where does this sort of settle into over time? And so that's why it's relative to 0 is because that was relative to that peak, and then where did it go from there? And so lower means less effort. And what we did here then was to use more sound intelligence off, the noise reduction system off, and looked at effort over time. And then you turn it on, and you can see what that looks like over time. So again, less effort being expended, not just at that orienting point, but then actually over time as well. We did this in another situation, 29 patients, mild to moderate hearing loss, and we were using, in this case, sudden sound stabilizer. So this was Oticon Real. And again, I showed you this setup earlier where they were listening to the noise with the sudden sounds, trying to be distractors, right? So you've got speech coming from the front, sudden sounds coming from off to the sides, background noise happening. So lots going on here trying to throw this person off from being able to follow the conversation. And we're looking at, got the eye tracker in front while they're doing the task as well. So these were the same people, by the way, who had the EEG cap on. So we put a lot of stuff on them all at once. You can do all of it at the same time, which actually kind of helps. And so what you could see with the pupil dilation, what you have here is, like, in the background noise. In this case, you're presenting the target sentence, and then you'll have these sudden sounds interspersed in there. And so we've got 3 plots here. One is, okay, let's say we didn't do the sudden sounds. What would just listening to that speech look like? That's what this looks like. So we're looking for that peak here, okay? And then if you have sudden sound stabilizer off, where the transients are being amplified, but they are not being dealt with that feature, you can see you actually expend a lot more effort because you've got these distracting sounds happening at the same time that you're listening to the speech, right? So you have to expend more effort, your pupils dilate in response to that. And that's going to happen with distracting sounds. There's no way around that. It is good. It's going to be what it's going to be. But the question is, can we make it less distracting? Can we make it less effortful when they hear those sounds? And that's what you see plotted here with the magenta line, is that, yes, there's still more effort being expended than if those sudden sounds weren't there at all, but you can actually see a decrease here. This is actually really something that is of great interest to military, Veterans Hospital, kind of really interested in this, and they actually did some research. I don't have it on here, but they actually did research in Denmark with the Danish service, and those veterans are they're considered veterans when they were in combat. So these are all combat veterans, and a lot of them had PTSD and had a really exaggerated response to sudden sounds, and so this was actually of really big interest to them. All right, and then lastly, we did listening effort via pupillometry for Oticon Intent. Now, I mentioned with Oticon Intent, we're having body and head movements to help try to inform the hearing aid about what you're trying to listen to, so what's your listening intention. That's why it's called intent. And so trying to do EEG and pupil dilation measurements while somebody's moving around is a little bit more complicated still, okay? Right, so we had to come up with what's a better way to do that. So there was actually a study that was done at Denmark Technical University. They have a really cool lab where you could do this. And they did this with hearing aid users wearing Oticon Intent devices. And I actually got to go and do this. So that's me in the picture. I just got to experience what the paradigm looked like. And I don't know if you can see kind of like down here. This is what I was seeing underneath the goggles. Okay, so I was seeing 15 different avatars lined up in front of me. And then I've got this little thing in my hand to where I needed to point to who was speaking. So you've got all these speakers up around me, like at head height. And then you've got the goggles where I'm seeing this virtual reality scene of these avatars, but at the same time, it's also recording my pupil dilation. So there's a camera inside the goggles in order to do that. All right. So this is a really complicated experiment for these people. They had 15 different speakers set up, and so what I was seeing was 15 different avatars, and there was a noise coming from the speaker array in the back, and then any one of these people could have started talking, any one of the avatars. All right, so in fact, 2 of them started talking at the same time. One was telling a story about jellyfish, and one was telling a story about skiing. And so the instructions that you would give to the subject were, find the person who's talking about skiing, and then you're going to listen to their story, okay? And they were randomly coming on. It was a really difficult task. So it's like basically trying to create a cocktail party environment, right, to where you're actually able then to focus and orient and then focus in on, and listen. And that was important because the way intent works, you're going to have more access to the sounds around you when your head is moving and when you're trying to orient to something. And then when you stop and you focus in and you're not moving around anymore and there's conversation happening and it's a noisy situation, the assumption is that you're now trying to listen to somebody. And so you're going to get more support in noise via both the directionality and the noise reduction system. Okay, so that's what we wanted to see is, we wanted to see what this effect would be like when you're actually doing these movements and so on. So it was a very difficult task for me particularly because it was in Danish. So I'm working on my Duolingo, but not going that well yet. That was cute. All right. And then they actually did an even more difficult task, which was to do this with 4 different avatars who were speaking. Okay, so now you've got a whole really complicated scenario, and you got to listen for Pac-Man and listen to the story there. So under these circumstances, we were looking at sustained listening effort. And so what you see over on the left here is with the 2-talker scenario, and on the right is with the 4-speaker scenario. And so you can see that with Oticon Real, so that was the previous version of our best hearing aid, you can see that you get a reduction in listening effort as the person settles into the task with these 2 speakers. But with intent, you could see that there was a reduction over time, okay? So they were able to focus in a little bit more with intent compared to Real. Then when you see the 4 speakers, you can see that, you don't get as much of a decrease as you do with the 2 speakers because it was a more difficult situation to begin with. But you do, again, continue to see this improvement in reduction with intent versus Real. Okay, so that the accelerometers that were in the device did help these people be able to focus in more with the listening effort. So lesson here, you can use pupil dilation to measure effort being expended, and that you can use to show group effects of reduced listening effort in response to a whole bunch of different auditory factors. One of the challenges that we have, while it is getting easier to do these recordings, we're still at a place where on an individual, you may or may not show this effect in real time. And because it's ongoing effort, you can tire somebody out if you do the task too many times, right? So it's not like an ABR where you can just do thousands and thousands of clicks. You have to measure it over time slowly, and the more times that you do that to do the signal averaging, then you start to wear that person out, right? And so there's a signal averaging component to this that sort of needs to happen that also can't happen because you're measuring effort. And so you have to do multiple people, and when you do groups of people, then you can see the difference. Okay, so that's why we haven't been able to bring it forward for clinical practice yet, is we need to come up with a way to extract the ongoing signal in terms of what's that effort look like, but without actually fatiguing people in order to do it. Okay, so that's what's the holdup with that, but hopefully somebody will be able to figure this out. AI may be able to help us pull those patterns out easier over time. Because this would be ideal, wouldn't it? For you to have in your clinic and go, yeah, actually this is easier for you. This is how your hearing aid should be programmed. This is the technology I'm choosing for you because you want this to happen, and this will get you there faster, right? All right. The newest metric that we've been using is stress via heart rate. So again, kind of came together in a group a few years ago now, to define listening stress, so a specific form of stress that is experienced when a task involves listening to noise. And this happens for all sorts of good reasons. I'm sorry, I forgot to stop. Does anybody have any questions about the listening effort pupillometry? No? Okay. So listening stress is sort of a corollary of listening effort, right? So if you're having to expend a lot of effort, it would be inherently kind of stressful, right? But just like before when we were talking about usage, benefit, satisfaction, they're not exactly the same things. So they're related, but they're not exactly the same, and we can measure them using different parameters. And there's still a lot we don't know about listening stress, but we're starting the work to try to understand what's happening with people from a listening stress perspective. How well could we measure it? What's going on with it under certain circumstances of listening? And then how does it relate to things like effort? How does it relate to things like attention, and so on? So the researchers at Ericsholm are doing those types of work as we speak. Well, maybe not Sunday, but Saturday. It's Saturday, right? It's been a long week. So they're doing this type of work, and but again, we got to use a little bit of it to investigate the impact on the hearing aids right now. So why do you have hearing to begin with? It was evolutionarily advantageous to be able to hear, and a lot of animals use their ears to scan for danger, and we do too. Last night I was walking out afterward, and it was dark out, right? So you're like looking around you and paying attention, and I tripped over the curb, which was fabulous, but I couldn't see, but I could hear, which was great. But you're scanning for danger, right? And just again, think about that orient and focus subsystems and how important those are. Your brain is not going to let you bypass that orient system, by the way. So for years, we've been trying to kind of overcome the problems that people have sorting out the sound scene by just sort of narrowing in using traditional directionality. And it does improve the signal-to-noise ratio, which can help, but at the same time, when it doesn't clarify the entire sound scene, your brain's working really hard to continue to do that. It's not going to stop doing that. It's designed to do that. And so, again, we kind of feel like if you can give that part of the brain, that orient system, a really good signal, it can do a good job of figuring out what's going on and allow you to focus appropriately. But yeah, so we're scanning for danger using our hearing. And so there's a pretty direct relationship between certain sounds and heart rate. You guys know this, right? I mean, there's a lot. There are a lot of sounds out there where you hear that and you are oriented and you are focused and your heart rate goes up, right? There are a lot of sounds out there like that, and that's the way it's supposed to be. But the challenge is we hear a lot of those sounds nowadays. It's not just that some lion is trying to eat us. There's a lot of those sounds to go around. So you've got sound levels nowadays that we didn't used to face, and maybe some other animals didn't used to have to face. And those sound levels, just general intensity of sound, will raise your heart rate. There's also environmental complexity. So you're a human, and you're a social being, you're a social animal, and you're working really hard to engage. You're listening to me. There's sounds going on in the background. You're in your office all day long. Whatever it is that you're doing, you have a lot of environmental complexity happening around you, and you're trying to engage and focus because that's what we do. And so both of those things are going to cause stress in your body. And again, from an evolutionary perspective, it's really good because when your heart rate goes up when you experience stress to get you ready to do something. It's a fight or flight kind of a thing, right? And so if that is, in fact, a lion, that is a reason that you're hearing a sound, it's really good if your heart rate jumps up because now your body is going to have what it needs to move really quickly, okay? And so we want to see that happen. It's not a bad thing, but the cumulative effects of it over time is something that we don't understand a lot about. And so we just know, like, we sort of have this sense that maybe we don't want stress to be very high when we're listening because, again, there are potential consequences to that. So with heart rate monitoring, it's sort of a different perspective of what's happening in the brain because the brain is fed oxygen, glucose, right, from your heart pumping. And so we can actually sort of use it as a little bit of a proxy for what's going on in the brain in terms of stress. And so so that's what we looked at here, and we wanted to look at objective stress. So again, we've used some metrics in the past, and there are other published studies out there correlating stress as measured by heart rate with subjective stress. Okay, so we have already done that in the past. We didn't do it. We're relying on other research that's shown that relationship. And so we're kind of jumping straight to the objective component here. And we wanted to do a very complex listening scene. And so the good news is you already heard me set all of this up. So the people who were sitting there with that virtual reality sound scene, where they're listening to the 2 speakers versus the 4 avatars, background noise, and they had the goggles on, looking at their pupil dilation. At the same time, they were recording their heart rate using a heart rate monitor. Okay, so exact same scenario. And then what they did was to look at the change in heart rate when you went and increased the sound scene complexity. So remember how we had the 2 sound scenes, the 2 speakers versus the 4 speakers. Just like pupillometry, there are a lot of things that can affect heart rate. And so you have to do one thing at a time. And we needed to establish a baseline for heart rate. And so the baseline here is the 2-speaker condition, the one that wasn't as hard. So I said, okay, this is what the stress is involved with hearing 2 speakers. Now we're going to make it more difficult by adding in another couple speakers, more complex sound scene, more difficult task. And we want to see how does the heart rate change when we make the situation more complicated, okay? So that is the change in heart rate that you're looking at here over time. And we just wanted to see, again, what happens from an ongoing speech signal. And you can see, so this is Oticon Real. So this is our best hearing aid. And you can see how that changes over time. So the more complex environment, your heart rate increases, as you would expect. What we were able to see with intent, however, is that over the course of that time, we actually saw that kind of drop down back to the baseline for the 2 speakers. So initially, it is a more difficult situation where you have to orient, again, to the correct speaker. But then once you did and you were able to focus in, it actually went down back to the baseline. So basically what you're seeing here is that towards the end here, after these about 30 seconds or so, they were back to, while they were listening to the 4 speakers, they were back to the same heart rate as when they were listening to the 2 speakers. So we don't 100% know what that means, but it's actually potentially suggesting, right, that you can actually decrease that listening stress using certain parameters of the hearing aid, okay? So that was the what we were seeing here. So there's still this, again, in its infancy, a lot more to be done here in terms of understanding all of these relationships, but this was a good start for us here. So summary of that, you can measure heart rate to understand how much physical stress is being expended on listening tasks. You can show group effects of reduced listening stress in response to certain auditory tasks, and you can adjust hearing signal processing parameters and actually see some of those effects as well. Okay, so pause there again. Any questions about stress? You're all feeling it. All right, so why does any of this matter? We're trying to do something, right? We're trying to communicate. We need cognitive resources in order to communicate. Communication is not a hearing task. It is a very cognitively effortful task to communicate with other people. You need speech understanding. You need to pay attention to what they're saying. You need to understand what they're saying. You need to engage. You need to behave appropriately and say appropriate things in response to what they're saying, right? There's a lot going on when you're communicating with somebody. And so you need cognitive resources in order to do that. But the fact is, cognitive resources can be quite limited. And depending on how much of a task you're exerting, or how much effort you're exerting on one task, that actually reduces how much cognitive reserve you have left over to do other tasks. And I never like to think that. I always like to think like, no, you're going to be able to do everything. But I've had plenty of experiences in my life where it's like, no. If you're overwhelmed and stressed, you cannot do everything all at once, right? And the older your brain gets, you see this more over the years, right? That it's just harder to do everything all the time. my brother died last week, and no, sorry, I felt like I had a concussion. And I'd had a concussion about a year ago. And so I took a few days off because I'm like, I'm not going to be good to anybody, But it was, that was what I felt like. I felt foggy, right? Like I couldn't focus, I couldn't pay attention because my body and my brain were under a lot of stress, right? So this happens. This is a real thing that if you're under too much stress, your brain just can't do and engage in other tasks, right? So cognitive reserve matters, and so being able to show that there's reductions in effort, that we don't have to work as hard, that we're not as stressed, gives us the opportunity to have that cognitive reserve left over to do something else. So when that person comes in and they're like, my wife's mad because I can't hear, she's not mad because you can't hear. She's annoyed, right? But she's having trouble communicating with you. Hearing better is going to get you part of the way. But you also need to pay attention, right? You also need to be able to be present and have that conversation and not just be hearing, right? And so that's where these metrics, I think, are particularly important to us. Again, just what are we trying to achieve, right? So this was one of the earliest studies we did, and we haven't replicated this one yet, but I'm hoping we will sometime in the future, but to really just understand the workload and the impact on the brain. So you've got this incoming speech, and really what your brain is doing is kind of matching it to long-term memory. Does it understand? When I listen to Danish, not so much. I can hear Danish. Can I understand it? No. There's nothing in my brain that's going to allow me to interpret that, right? And so when I do, and I'm really trying. I watch this show on Netflix, and I do my Duolingo. When I watch the show on Netflix, I can watch a little bit at a time, and then it's like, what did they say? I have to process it offline, right? It's effortful, right? When you don't have a match up here to understand it. You can hear something and not understand it, and you're going to have to use a lot more efforts to do that when you don't have that match, when you don't have the resources to work with. So we actually did a test to understand, this was back with Open and Open Sound Navigator. There was a test called the SWIR, Sentence Final Word Identification and Recall. So you remember that task, well, very first one I showed you, where they're listening to those two speakers and there was background noise. And they listened to the sentence, and we were recording their pupils while they did that. And they repeated the last word of the sentence. Well, then what they did was say, hey, go back and tell me the last 7 words you repeated. Okay. Ooh, yeah, I know, it's not a good, none of us want to do that. But they dutifully did it because they were wonderful subjects. And so, and you have a few types of responses. There's, it's normal that you would remember better the first few words that you heard. It's normal that you would remember the last couple words. It's normal that you would forget everything in between. That's a known psychological phenomenon. We saw all of that with these people. But the percentage of words that they could correctly recall did differ between whether or not they had that noise reduction strategy on. And when they had it on, which is this gray line, versus off, they had significantly more correct words recalled because they could hear better, because the signal-to-noise ratio was better, the signal was more salient to the brain, they were expending less effort, and therefore they had more cognitive reserve left over to do this memory task. Right. This was done originally in Danish, and then it was repeated in Swedish, and so that's why you see both of these results here. Those were just 2 separate studies demonstrating the same effects. So you can use short and long-term memory tasks to estimate cognitive reserve with that's left over after listening effort and stress. And again, you can use this as a metric for some of the hearing aid signal processing features and so on. So I'm going to move on here, but any questions about that or comments, discussion? Yes. 1 second, sorry.
So just curious to know if all these features are available only in the top-level technology, or the chip is in all of those levels of technologies?
Yeah, we use the same technologies across levels. It's just a question of how much flexibility you have in the programming. So like the maximum amount of noise reduction programming that you can get with the highest level of technology is is more than what you can get in the lower levels of technology. But pretty much across, when we get to our lowest levels, now we're going back to like Open Sound Navigator in like our lowest level products like Zircon, but we use the same strategies across all of the other levels. Yep. So it's really just the degree to which you're using the noise reduction. Yep. Any other questions? Yes. Oh, hold on. Let me give you this.
Is the AI measured as well? Like I was telling one of the patients, and the patient was saying, "Oh, you mean to tell me that it's following me everywhere?"
When you say measured, what do you mean?
Like in the software, can we see it or any?
Gotcha, okay.
I know in data logging we can take a look at different environments.
Yeah, you can see sort of what environments they've been in, but the AI itself, you don't really see what it's doing because it's just, nor do you see like when you go into directionality, right? Because it's automatic, right? So you can see like in the data logging, these are the types of environments they were in. And then you can see, and then basically the more difficult the environment, the more active the noise reduction system would be. Yeah, yep. Yeah, so you don't really see what's going on. And that's something that people don't like about AI, but you don't really see what's going on with the compression or gain or anything else either in the moment because it's all dynamic, right? You can see the effects sort of in things like this. You can see the effects when you turn off the noise reduction and you're doing speech testing. You can do all sorts of metrics. You can do some technical measurements and so on, but like the ongoing work of it, there's not a really good way to see that other than, just trying to get in there and understanding what is happening over time within the brain. Yep. Great, okay. Well, since none of those things are available to you right now, I will leave you with a solution. Again, we are working to try to bring these things to life, not just as metrics, not just to understand what's happening, but it would be nice if you could use some of these things clinically at some point to be able to inform your clinical decision-making. Right now, most of what you have is our white papers when it comes to application of these technologies to the hearing aids. There are other publications out there where, again, more general, and you can see some evidence-based research that's more independently published. My soapbox here is that I know that everybody wants to have independent peer-reviewed research for their hearing aid stuff, and the problem is the peer review process takes so long that we just can't get it out in time for you to have that, and so there's always this big lag before it can get published. There are also requirements about usability from the EU, so we can't just go out and do research using a prototype device and then say that the results are the same as a regular device. So to some extent, you have to just wait until it's launched in order to do the research, so then 2 years later, you get to find out that this worked, which is a little late because now we'll have moved on to something else in terms of the technology. This is a big problem for all sorts of reasons in just general scientific literature, but for what it's worth, that's why you don't always have all of those day one. There's also a question of who's going to fund the research, and so we have to fund our own research because who else is going to, right? So there's always these little things where we always wish we could have everything be independent and peer reviewed and so on, and it's just not quite feasible in the timeline that we want for it to be there in order to make these good clinical decisions. Anyway, in the interim, since we don't have these things available for you to make those decisions in the clinic, I'm going to go full circle back to where we were yesterday and say that the cozy is probably your best friend in terms of metrics, right? Establishing your own objectives, the ones that are most important to the patient, and then understanding whether you have accomplished what your intentions were. Right? That's what we need to do to get us closer to really being able to demonstrate benefits, to understand whether our treatments are effective. And there are plenty of validated metrics with all sorts of subscales and everything Is it going to show you what you need for your patient? Maybe, hopefully, that would be great. My guess is, in most cases, it's not going to show differences because it usually doesn't in research, and it probably won't in most cases for your patients either. And so, at the very least, something like the COSI is going to be very sensitive to your patient's experience, and so using this as a validated outcome metric is something that I would highly advocate. And again, it's there in NOAA, so you can access it on your own. And so with that, I think that's about it. I showed you this yesterday. Oh, one other thing just to tack on there. Previous users, especially previous users, doing something like the AFAB, all these other things, they are really not going to see differences. It's one thing to go from non-use to use. It's a very different thing from using this device to using that device. Those are really nuanced differences in outcomes. Your patients, as you all know, they get new technology like, this is cool, I love this. They are very happy. Will you show any differences on an AFAB or any of the other metrics? No, right? Because the differences are really subtle because the things they're thinking about, yes, there's specific situations that they have better understanding of, but they've gotten the bulk of it already. Like they're at the 90% point of what they're getting if they're already fit well with hearing aids. But we want to give them a little bit more. But what isn't represented on these questionnaires in most cases, they just like the sound quality better. Fewer instances of feedback, greater convenience on the phone, music, rechargeability, television. Those things aren't represented on any of those. And those are things that our patients do pay attention to, and it really contributes to their success and use of the amplification so that they can benefit. And so this is, I think, particularly important when it comes to previous users and documenting benefits. So that is everything that I have. And questions, comments, discussion?
This is just a comment. Since we don't have this yet pupillometry, I was just thinking, why can't somebody just do a revised AFAB, and instead of using the 1990s technology, just use the neural network hearing aids?
Yeah.
So.
Yeah, I mean, what happens is when you'd have to revise the whole test, right? Yeah, so you can't just do it with the new technologies because then it just shows no differences. And that's what we see a lot of, and people say this all the time. They'll be like, oh, there's no differences in technologies from higher end hearing aids, slower end hearing aids. Using a metric like that, yeah, they're not going to be. And so you'd need to actually redo the entire test. And people do make efforts to do that. I think in the end, the challenge is that it's a composite score of a whole bunch of different things. So you'd have to assume that all of those things were relevant to that patient, and you're working on all of those things, and that they're equally important for the patient. Right? Because there's no sense in those metrics either of, oh, this is the thing that was most important to me. This is the thing that I was really focused on. And yeah, this other thing also may be improved, but I don't care, right? Because that wasn't why I came in. So I think that's the challenge, is that you can do those things, but your likelihood of seeing a difference just goes down the more generic the metric is. And the more comprehensive the metric is, when you take a composite score, your ability to see differences goes down, just because of the math. Yeah. Like I said, it's like that kid, the kid you send off to college and comes back and gets the remote mic. You have nailed it. You have solved this problem 100%, and you won't show any difference when you get a composite score. Yeah. Can you give him a microphone? Sorry. Hold on one second. Sorry.
I'm sorry. Wondering if AI or machine learning is also looking into voice recognition for hearing aids, so they can, pick and choose. These 5 people, my hearing aid want to improve the signal-to-noise ratio in a noisy environment like restaurants. Are they looking into those areas?
They look into everything like that, yeah. And it's always a question of, is it going to be useful to a person or not in those types of situations? So absolutely, it is something that is under investigation. Yeah, you know, can you train it to pay attention to specific voices and pull those out because those are your primary communication partners? Yeah, there's all sorts of work that goes on around those topics. And because, yeah, it's again, nowadays it's much less about what you can do than about what you should do. And that's where Eric's home, our researchers there are kind of really focused. Like, where is that a good idea, right? It sounds like a good idea, kind of, but is it proven to be a good idea? And that's the type of research that they're going after is like, you know, okay, well, let's say we could do that. What would that look like in your day-to-day life? Would it be helpful? Would it not be helpful? What does your stress look like? What does your effort look like and all that? Yep. Okay. Well, then I will wrap up here.